the LEAP model is a modified motivational interviewing, an approach for active listening. Some of you may be familiar with the notion of motivational interviewing, a whole technique that was developed and tested for substance abuse and has been very, very effective in substance abuse and many other things. I'm not teaching motivational interviewing. I'm just stealing some ideas from motivational interviewing, but it's actually a wonderful therapeutic technique, and we're going to borrow some of the things that it uses, and we're going to borrow them through this acronym of LEAP. And LEAP will stand for listen, empathize, educate, and exchange. So the E has three meanings: agree, partner, plan, and proceed. So the P also has a couple of meanings. Now, I want to block all of these out, and I want to point out that as clinicians, when we tend to talk to people, we are focused so heavily on the planning and proceeding. When we ask questions, we're immediately thinking about what is my treatment plan going to be? What am I going to do for the patient? How do I respond? And I'm going right to the plan and proceed. I'm trying to come up with a plan. I'm focused on that. And when I am focused on that, I can't be really listening to the patient in real time because I'm focusing on the next step. And so then we wonder why patients are non-adherent. Well, because we went right to the plan and proceed. We didn't get them on our side. We didn't get on their side. And now this is natural because that's your job. Your job is to come up with a treatment plan and to proceed with a treatment plan. But the idea here is to take a pause and not go to that. There used to be an old Red Cross saying, which was, in case of emergency, don't just do something, stand there. Don't just do something, stand there. In other words, take the time to think through what's important before you act. So let's go through each of these, the steps of this acronym individually. The first one is LEAP, is having to do with listening. Well, what do we mean by listening? We have active listening. How do patients listen? How long? So let's take a think of how things are now. How long do clinicians listen to patients' initial presentation? The answer is that research has shown that there's different research on this, and I put a couple of papers down here if you want to get these references and read them. But there's a lot of research that shows that it's about 11 seconds, right? That clinicians will say, this is especially true for primary care clinicians. Unfortunately, we have very little time, or for a cardiologist, say, well, tell me what the problem is, and they will listen for 11 seconds before interrupting. So that is not active listening. So how do you do the active listening? How do you do that? Well, first of all, you don't interrupt in 11 seconds, right? Know your quadrant. Listen for needs, okay? And watch for the nonverbals. Focus on their perspective and especially their needs in the moment. So you say to yourself, I'm going to put aside my plan. I'm not going to get to my plan yet. What I'm going to focus on is, what is this person's need in the moment? What do they need in the moment? And from life, a great example from life is just a baby crying. Right? I mean, those of you who are parents or who have nephews or nieces or little children in your life, when you have a little baby that's crying, right, can't verbalize its needs, really we spend a lot of time trying to figure out, what is it? What is the need that's being expressed here, right? And so use that example about active listening. You're really actively listening to that cry and trying to figure it out. Ask yourself, what does this person want me to hear? What do they want me to believe? What do they want me to understand about them? And try to see the problems from the patient perspective, not the clinical one. You know, we're often trapped in a thing that we know a whole lot about a particular disorder, about a particular problem. The patient doesn't, and we're trying to quickly get them to be as wise as us. You know, I know the answer. But if you start from that perspective, you're just going to get pushback. So the idea is, no, don't start from where I am, my knowledge and wisdom. It's start from where they are. All good teaching start from where they are. Now, here's the important thing about empathy that's often not told, which is that the most important thing about clinical empathy is not how you feel, but what you communicate, that you let them know that you're understanding, that you give them a signal that you're listening, okay? Because if you're very empathic and say, oh my God, I really feel this patient's pain, I know the pain and stuff like that, and you're silent about it or you lock it up, which is the way some of us were trained, by the way, then they don't understand that you understand. And if they don't understand that you understand, you haven't communicated, right? Because communication is getting you both to understand the same thing.